Once again, welcome to Medico Mallu. Today we are going to discuss the topic acute pancreatitis. From the name itself, it is understood that it is an acute inflammation of the pancreas due to many etiologies. And coming to the etiology part, the gallstones are the most common reason more than the alcohol. But in India, especially in south part, that is in Kerala, alcohol is found to be a more common cause of acute pancreatitis. And listing out the etiology, gallstones, alcohol, hypertriglyceridemia, that is increased triglyceride levels, ERCP, that is post the procedure, post operative procedures, trauma, prolonged bedridden, chronically ill patient, patient after radiations for any malignancies, many drugs like azathioprine, estrogens, sulfonamides, valproate, etc., can cause acute pancreatitis. So the uncommon causes are vascular reasons, vascular etiologies or vascular diseases, vasculitis, cystic fibrosis, infections like mumps, cytomegalovirus, and autoimmune conditions are other uncommon causes. So there is an entity called recurrent pancreatitis. So recurrent pancreatitis, there the etiology are disease of the biliary tree or the disease of the pancreatic ducts, metabolic causes like hypertriglyceridemia, we have discussed that, and hypercalcemia also. So this increased triglyceride levels may be due to apolipoprotein C2 deficiency, which is essential for the clearing of chylomicrons. This increased triglyceride levels can also be seen in recurrent DKA and diabetes mellitus and during use of certain OCPs. So other causes of recurrent pancreatitis are anatomic irregularities or abnormalities like pancreatic divisum, cystic fibrosis, some idiopathic causes that we don't know, and alcoholic abuse, etc. Coming to the pathogenesis can be of two types based on the two types of pancreatitis. The pancreatitis most common presentations are interstitial pancreatitis and the second one is necrotizing pancreatitis, and the pathogenesis are more or less similar, but some differences are seen. In interstitial pancreatitis, it is a self-limiting condition. Here the blood supply is intact, whereas in necrotizing pancreatitis the tissue are dead, which means the blood supply has been cut off, and it can result in many systemic complications. So how does this pancreatitis occur? It is due to autodigestion. So what do you mean by that autodigestion? It is that we know that there are proteolytic enzymes in the pancreas secreted by the pancreas, and once these proteolytic enzymes get activated in the pancreatic acinar cells rather than in the interstitial lumen, this digestive enzymes digest their own organ, its own organ, like pancreas itself. So the enzymes are trypsinogen, chymotrypsinogen, proelastase, lipolytic enzymes like phospholipase A2, etc. So there occurs this premature activation due to many reasons. That is the etiology. Due to endotoxins or exotoxins, viral infections, ischemia, oxidative stress, trauma. All this can cause this premature activation of these enzymes, which causes the autodigestion, and it results in pancreatic tissue digestion. Peripancreatic tissues also get digested. So there is a clinical course has been explained by a revised Atlanta criteria, where it defines the phases of acute pancreatitis, it defines the severity of acute pancreatitis, and also it gives the imaging definitions of acute pancreatitis. So coming to the phases of this disease, as explained by the revised Atlanta criteria, it can be divided into three phases. The initial phase is the intrapancreatic digestive enzyme activation and the acinar cell injury. And the second phase is intrapancreatic inflammatory reaction after this digestive enzyme activation and acinar cell injury. And here there will be activation on chemoattraction, sequestration of leukocytes, and also macrophages in the pancreas. And the third phase is the effects on the distant organs, where these proteolytic enzymes and cytokines act in distant organs. So that's the three phases of the acute pancreatitis. So this is an image, pictorial representation of the incidences what is happening in this acute pancreatitis. And initially there is a cell injury and death of the pancreatic tissues, which results in bradykinin and vasoactive substance histamine releases, and this causes vasodilatation, increased vascular permeability, and edema on many other organs, which results in SIRS, ARDS, and multi-organ failure. So how do we approach the patient? So how does the patient presents to us initially? The major symptom is the abdominal pain. And what's the characteristic of the pain? There is a steady and boring type of the pain at the epigastrium and periumbilical region, which can radiate to the back, chest, or flanks. And associated with this pain, there can be nausea, vomiting, abdominal distension. And sometimes the patient can present with a more severe complication like shock. The patient can be in shock even in the initial presentation. So how does that occur? Because of hypovolemia due to secondary exudation of the blood and plasma proteins into the retroperitoneal space, and it can occur due to increased vascular permeability and vasodilatation that we have discussed in the earlier page. And the shock can also occur due to systemic effects of the proteolytic enzymes, the lipolytic enzymes in the circulation. And jaundice can also be seen. It is due to the edema of the pancreas, resulting in compression of the intrapancreatic portion of the CBD or its passage. Or it can be due to biliary stone or the sludge. Both these things can cause obstruction of the bile flow, resulting in jaundice. So some pulmonary findings can also be seen during the initial presentation. In around 10 to 20% of patients, there can be left-sided pleural effusion or left-sided atelectasis or basilar rales. And there will be features of enlarged pancreas. That enlarged pancreas is due to from acute fluid collection, or there can be a pseudosis, or there can be a vault of necrosis, and this can be palpable in the upper abdomen at around 4 to 6 weeks. So abdominal distension along with a palpable mass can be seen during the initial presentation. So these are this initial presentation of the patient. And two signs have been discussed in many textbooks. Like one is the Cullen sign. It is a sign of hemoperitoneum, where there is a faint blue discoloration around the umbilicus. And next is the Turner's sign. It's a blue, red, purple or a green blue discoloration of the flanks. It is a sign of severe necrotizing pancreatitis. Next, after initial general examination, we will send our labs. So what does the lab say to us? So we will focus on serum amylase and lipase, which is more than thrice its normal levels. And this lipase is the preferred test because it is more specific. Because amylase are seen in many other conditions, many other diseases, or even in many other physiological states. So, but there is no correlation between the severity as the degree of the serum lipase or amylase rise. We cannot say the prognosis, we cannot predict the prognosis of this disease, or we cannot predict the degree or severity of the disease based on the values of serum amylase or lipase. So after 3 to 7 days, even with evidence of the pancreatitis, the total amylase may return to the normal, but the pancreatic lipase levels remain high for 7 to 14 days. So that's why specificity is more with lipase. And also other causes of increased amylase are pancreatic tumor, pancreatic trauma, pancreatic carcinoma, renal insufficiency, salivary gland lesions, tumor of or carcinoma of lung, esophagus, breast, in case of burns after DKA, in pregnancy, ruptured ectopic, renal transplantation, drugs like opiates, biliary tract diseases like cholecystitis, choledocholithiasis, intra-abdominal diseases like perforated peptic ulcer disease, intestinal obstruction, peritonitis, all these can cause raised amylase. So that's why any elevated amylase is not specific to the pancreatitis. So next is coming to the common blood counts, that is complete blood count or the routine blood investigations. The leukocytosis, there will be increased WBC count. There can be hemoconcentration, which is a sign of severe disease, where the hematocrit will be more than 44%. There will be pre-renal azotemia, where there is blood urea nitrogen is more than 22. That is also predictive of high risk for mortality. So these hemoconcentration as well as the pre-renal azotemia is due to loss of plasma into the retroperitoneal space or the peritoneal cavity. And there can be hyperglycemia due to reduced insulin secretion or due to increased glucagon secretion as part of the pancreatitis inflammation. And there can be hypocalcemia, which is seen around 25% of cases due to intraperitoneal saponification, where the calcium will be used up. And there can be hyperbilirubinemia or elevated liver enzymes. Both these can be seen in gallbladder disease or pancreatic head inflammation. Hypertriglyceridemia and hypoxia is seen in severe conditions where the patient might be in ARDS. And ECG abnormalities are also seen in some cases where the abnormal ST and T wave elevation, which can simulate the myocardial ischemia. So coming to the diagnosis, there is a revised Atlanta criteria, which says 3 points. The first one is typical abdominal pain in the epigastrium, which may radiate to the back. Next is more than or equal to 3 times increase in serum lipase and or amylase. Third one is abdominal imaging, which is suggestive of the pancreatitis. So these 3 are the revised Atlanta criteria. And few markers of severity also we have to keep in mind. One is hemoconcentration, we have seen that. Next is azotemia. On this hemoconcentration as well as azotemia are assessed during admission or within 24 hours, and that has got more prognostic value. Then SIRS, then signs of organ failure. Then we have to keep in mind the differential diagnosis before coming to the conclusion of acute pancreatitis. So some other conditions can also mimic the features of acute pancreatitis. They are perforated viscous like peptic ulcer perforation, acute cholecystitis or biliary colic, acute or intestinal obstruction, acute mesenteric vascular obstruction, renal colic, inferior myocardial infarction, dissecting aortic aneurysm, connective tissue disorders with vasculitis, pneumonia, DKA. These are the other differential diagnoses of this pancreatitis, acute pancreatitis. Then the phases based on the hospital course, we can divide into 2, early phase as well as late phase. So the early phase is less than 2 weeks, whereas the late phase is more than 2 weeks. So early phase, which lasts around 1 to 2 weeks, where most of the patient exhibit the systemic inflammatory response syndrome, that is SIRS. If it is persisting, it may result in organ failure. So here in this early phase, the CT imaging is not recommended during the first 48 hours of admission. So next phase is the late phase, where the patient may need supportive measures like dialysis, ventilator support, Rice tube feeding or parenteral feeding. Here there are chances of developing complications, so we have to do a CT imaging in this phase. So this is the table similar to that of given in the Harrison's, where it shows the revised Atlanta definitions of the morphological features, where the interstitial pancreatitis is the most common morphological finding, where around 90 to 95% is the incidence. Next is the necrotizing pancreatitis, which is 5 to 10% in incidence. And there are other some entities like acute pancreatic fluid collection and pancreatic pseudocyst, where there is an encapsulated collection of fluid with a well-defined inflammatory wall, usually outside the pancreas with minimal or no necrosis. This usually occurs more than 4 weeks after the onset of interstitial edematous pancreatitis. Next is acute necrotic collection, where there is a necrosis. And next is the ward of necrosis, where there is a mature encapsulated collection of pancreatic and or peripancreatic necrosis that has developed a well-defined inflammatory wall. Here, a well-defined inflammatory wall is seen, unlike to the pseudocyst. So next is based on the severity, we can divide the acute pancreatitis into mild, moderate, and severe acute pancreatitis. The mild acute pancreatitis is there is no complication or no organ failure. It is self-limited. There will be spontaneous resolution, and oral intake is resumed earlier, and there is good prognosis. Whereas this moderately severe acute pancreatitis, there is a transient organ failure, or there is a local or systemic complications are seen with or without necrosis. They may have fluid collection, but there is no persistent organ failure also. In severe acute pancreatitis, there is a persistent organ failure. There is single or multiple organs will get affected, and here MRI or CT are required for ruling out complications. And the most common organ systems involved are respiratory system, cardiovascular system, and renal system. Coming to the severe acute pancreatitis, the risk factors for the severity, for risk factors for worsening of this condition are age more than 60 years, obesity where the BMI is more than 30, and comorbidities. So the markers of severity at admission or within 24 hours are features of SIRS, Apache 2 score, hemoconcentration more than 44 hematocrit, admission time blood urine nitrogen is which is more than 22, BISAP score, organ failure assessed with modified Marshall score, and systolic BP less than 90, which is suggestive of shock, and there is tachycardia, and partial pressure of oxygen is less than 60, which is hypoxia, and worsening of serum creatinine, which is more than 2. So what are the features of SIRS, systemic inflammatory response syndrome? Where the first criteria is either there is hypothermia or there is hyperthermia. Second criteria is there is tachycardia. Third criteria is there is tachypnea and there is carbon dioxide washout. And fourth criteria is either there is leukocytosis or leukopenia, or there is 10% of band forms. So any 2 out of these 4 criteria satisfies the criteria of SIRS. And what is BISAP score? From the name itself, assume that it is a mnemonic, where the B is for the bun more than 25, I is for impaired mental status, S is for SIRS, A is for age more than 60 years, P is for pleural effusion. So this is the BISAP score. So these are the markers of severity assessed during admission or within 24 hours of admission. Finally, coming to the complications of the acute pancreatitis before going to the management. The complications can be local complications or it can be systemic complications. Local complications, there can be necrosis, which can be sterile or infected. There can be pancreatic fluid collection, pseudocyst, pancreatic ascites, disruption of main pancreatic duct or its secondary branches, thrombosis of the splenic or portal vein, pancreatic enteric fistula, bowel infarction, obstructive jaundice, etc. Coming to the systemic complications, almost all the organs can get affected with the severe acute pancreatitis. First is the pulmonary, where there can be pleural effusion, pneumonitis, ARDS. Next is cardiovascular, where there can be hypertension, hypovolemia, pericardial effusion, non-specific STT changes in the ECG, which can mimic MI, hematological changes like DIC, and gastrointestinal hemorrhage, which can be due to peptic ulcer disease, hemorrhagic pancreatic necrosis, portal or splenic vein thrombosis, or variceal hemorrhage. Renal can be due to azotemia, there can be oliguria, there can be acute tubular necrosis. In CNS, there can be fat emboli, psychosis. In metabolic, there can be hyperglycemia, hypertriglyceridemia, hypercalcemia, encephalopathy, and there can be fat necrosis seen in subcutaneous tissue, bone, and other miscellaneous areas like mediastinum or pleura. So these are the complications of acute pancreatitis. And the imaging, in the imaging, we have to perform a CT if we are suspecting any complication. It is best evaluated 3 to 5 days into hospitalization when the patient is not responding to supportive care and to look for its complications. So in the coronal view of the imaging, the CT scan, this is the pancreatic tail, and we can see a parenchymal necrotic area here. And this is the axial view looking from below. There is inflammatory changes to the anterior pararenal space. So this is the kidney, and this is the anterior pararenal space, and there is an inflammatory change seen. So this is the cycle. Initially, there is interstitial pancreatitis seen in the arrow mark here. After 6 days, it develops into necrotic area. After 2 months, there becomes a walled off necrosis. So finally, the management of this acute pancreatitis. Here, 80 to 85% of acute pancreatitis are self-limiting, but we have to give supportive measures like fluid resuscitation is very important. Next is management of pain. The most of the patients will be having severe pain, so we have to give adequate analgesia. Finally, oral feeding when tolerating. If not tolerated, prefer a nasogastric or nasojejunal feeding rather than a parenteral feeding. Okay, so this is a small flow chart depicting the the algorithm of treatment. Initially, the diagnosis of acute pancreatitis. Once it is diagnosed, we have to give rest to the pancreas, which is NPO, nilperoral. Next is, while keeping the NPO, we have to ensure aggressive fluid resuscitation to prevent shock, along with adequate analgesics. Next, we are assessing the severity, and we have to search for the etiologies and treat the cause simultaneously. And after that, during recovery, we have to start oral feeding. That is the next step after 2 to 3 days. So IV fluid RL or NS, we have to give a bolus of 1 to 1.5 liter, followed by a maintenance of 200 to 250 ml per hour. Okay, hope you have enjoyed the class. We have to ensure adequate urine output of more than 0.5 milliliter per kilogram, where RL is preferred more than NS. So how we how we assess the adequacy of the fluid resuscitation? We have to measure the hematocrit or blood urea nitrogen 8th hourly or 12th hourly. Thrice a day or twice a day we have to measure. Coming to the nutritional therapy, a low-fat solid diet is given, usually after 2 to 3 days of admission or once the abdominal pain is resolved. And the enteral therapy is more preferred than parenteral nutrition because the enteral nutrition maintains gut barrier integrity. It limits the bacterial translocation, and there is only fewer complications, and it is less expensive. Coming to the management of the local complications, we need multidisciplinary approach where we have to include a gastroenterology doctor in our team. A surgeon may be needed, interventional radiologist and intensive care specialist for the management of necrosis or the pseudocyst removal, like that. So in case of necrosis, we may need a percutaneous aspiration with the gram staining and culture of the aspiration, repeated FNAC, and pancreatic debridement, which is known as a necrosectomy. And pseudocyst mostly resolves over time, but sometimes the symptomatic collections may need surgery, endoscopy, or percutaneous interventions. And recurrent pancreatitis, around 25% cases have recurrent pancreatitis. Recurrence can have recurrence, and the major etiology is alcohol use and followed by cholelithiasis. So pancreatitis in AIDS, there is high incidence of pancreatitis in AIDS. There is high chance of recurrence in AIDS patient because of increased incidence of infections of pancreas with cytomegalovirus, cryptosporidium, mycobacterium avium complex, and also due to increased use of medications such as protease inhibitors, trimethoprim sulfamethoxazole, pentamidine, etc. So this is a few overview picture about acute pancreatitis. Please let me know your suggestions and your doubts in the comment section. Thank you.